Hello and welcome to Pain Unfiltered, where we go in-depth into the interventional pain and spine world with some of the top key opinion leaders and executives in the space. We are your hosts, Dr. Patrick Buchanan and Dr. Timothy Deere for this Aspen podcast. Let's get started. I'm Dr. Patrick Buchanan, and with me is my co-host, Dr. Timothy Deere. Tim, we just got back from the Nashville Aspen Collaborative Pain Summit. How are you feeling about that?
You know, Patrick, I feel fantastic, by the way, and nice to see you. I think it was everything we wanted it to be. We had ortho spine, we had neurosurgery, we had interventional radiology, we had interventional pain, anesthesiology, physiology, we had APPs, we had fellows, we had industry. We had all the players in the field that are so important to deliver a collaborative service to our patients to improve access and care, efficacy. We debated in a friendly, collegial way. We tried to resolve some issues. And I think it really sets the groundwork for our July meeting in Miami to have some of those same people come back. And some of the things we talked about, we'll look at problem solving on our next meeting together. So I'm very encouraged by that. So I would say it was a great success. And I think, again, it catapults us into Miami with great momentum. And I think we're going to really get rid of turf battles and start thinking more about turf togetherness, where we're on the same playing field and helping people. So great work. David Lee did a great job in the organization. I want to compliment David, and the whole team of Aspen did this fantastic work.
Absolutely. It was a great, team effort all around. It was great to see the fellows there, the APPs there, and then obviously the surgeons in the group and the pain and, like you said, neurology all come together. So looking forward to Aspen in Miami next year, and I think Aspen as well in London a year from now, Tim. So that should be exciting.
Should be fantastic.
Of course, we want to. Absolutely. Of course, we want to thank all our sponsors that have supported Aspen, especially this podcast, including Mainstay Medical, Saluda Medical, Nalu Medical, Medtronic, and Spinal Simplicity. So thank you guys for all your support. So Tim, there's been a significant push towards advancements in closed loop stimulation. And also the marketing of this technology as well. So we had Dr. Chakravarthy and Dr. Zeem on earlier this season to talk about Medtronic's closed loop system. And just want to, first of all, give Medtronic credit for entering the closed loop stimulation space and marketing this and giving patients access to this therapy as well. But are all closed loop systems the same? And so we have two experts in the field to discuss Saluda's spinal cord stimulation closed loop system. So I'd like to introduce Dr. Jason Pope and Dr. Johnathan Goree. How are you guys doing today?
Doing great. Thanks for having us. Looking forward to a really good conversation.
It's going to be fun.
Awesome. So let's start with you, Jason. Just want to introduce you. You're obviously the former past Aspen president, has done a lot of the research into this stuff. Just give a brief background of your training and any conflicts of interest you may want to talk about.
Yeah, thanks, Patrick. So I'm Jason Pope. I have a pain practice in Northern California. I had the pleasure of, in my tenure, working with Dr. Timothy Deere in West Virginia. Go Mountaineers. I am an anesthesiologist. I did my residency at Vanderbilt University in Nashville, which is why the Aspen Collaborative Council was so fun having it in Nashville. That's super fun. I would say that my exposure during that weekend was really focused on togetherness. It was focused on community, and I really enjoyed seeing players from a lot of different spaces and from a lot of industry partners getting together and trying to solve problems to help advance patient care. And we say that a lot, but I really actually felt it in Nashville. So it's really fun. Patrick, I've known you for a long time, and I so commend you when you do your non-industry sponsored study when you were looking at spinal cord stimulation and the multi-system trial, if you remember. We got that published some time ago. And I appreciate the opportunity to talk about some of these innovations in spinal cord stimulation. And what I've been focused on over the last handful of years is patient outcomes, but also really focused on physiologic closed loop controlled spinal cord stimulation. I was a part of the EVOKE study. I was a part of the ECAP study. I am a part of the Rosella study. I'm a part of the neural panel study. So I've had my hand in this a lot. And, I'm so glad that we have an opportunity to talk about physiologic closed loop controlled spinal cord stimulation again. I listened to the podcast that you guys did before, and I think I left with more questions than answers. So I'm happy to try to offer some answers.
Thanks, Jason. We'll get into that just a little bit. Johnathan, why don't you introduce yourself and talk about a little bit your background?
Yeah, no, I am. I'm an anesthesiologist. Also, did my training at Cornell. Did my first epidural with Sudhir Dewan, so always have to give a nod to him for helping me, kind of ushering me into this pain world. Fellowship training at Emory, and now I've been at the University of Arkansas for 10 years. Doesn't seem like that long, but time flies when you're having fun. So academic practice, was a fellowship director for a while. Now doing some more administrative stuff in the hospital, but really have focused, came back to Arkansas, came back home to really improve care in the area of the country that I grew up in, where care has been historically poor and access has been poor. And so like Jason, I think are like-minded in really focusing on how we can improve outcomes for this technology that we love. And we know works for patients, but how can we make it work better? And focusing in on improvements in this technology and really harnessing the new closed loop aspect of spinal cord stimulation has really been invigorating, and I think is helping us get there where we can more dependably say to a patient that we can make your quality of life better.
Great.
Awesome. Thanks, Jonathan. Go ahead, Tim.
No, I think I was just going to say that, in the next 25 minutes or so, we're going to try to get to a lot of the things that Jason, you said you had some unanswered questions from our previous podcast. I encourage everyone to go back and listen to Dr. Azim and Dr. Chakravarthi's podcast as well, because I think we'll be able to compare and contrast those two podcasts and what was said. But Jason, I just really want to open up again. I want to make sure we get through all the questions, so we'll kind of get to the point on each of these questions. But the question for you really is, we talked about the Evoke study, the ECAP study, which I've been a part of those as well. I think they're great studies and published in some very impactful journals. What is that type of closed loop? This Evoke closed loop. What is that? What's that mean when we talk about that physiological closed loop? Give our listeners a analysis of what that means, because I think that's one of the things you said you kind of came away from the last discussion, kind of wondering what the previous thing was all about.
Yeah, I appreciate the question. So I'll start by just saying that spinal cord stimulation traditionally has been fixed output. And what fixed output means is that we program the device and it delivers the same thing every single time that it delivers an impulse to the spinal cord. And we know that we're placing a lead in a dynamic space, which is the epidural space. And we know that that space moves. So if you're using a fixed output system, by definition, based on the inherent nature of the dynamic space of the epidural space, it will essentially overstimulate and understimulate multiple times throughout the day. And I think when we looked historically at spinal cord stimulation, we think of some of these headwinds with durability, and Johnathan talked about predictability of the therapy. And I think when we moved from traditional spinal cord stimulation to paresthesia-free spinal cord stimulation, it was an answer to the wrong question. The question is, what are we doing to the spinal cord? Are we activating the spinal cord or not? Before we had physiologic closed loop controlled spinal cord stimulation, it was a black box because we don't know. We don't have a dose response curve. We don't know how much the spinal cord needs to actually create neural activation. And we wrote a paper that's in peer review through Aspen, looking at physiologic closed loop controlled spinal cord stimulation. There was a guidance that was put out by the FDA about physiologic closed loop controlled devices. And I'll pass it over to Johnathan to help answer this question. But I would say largely, the ECAP is the evoked compound action potential. It is an extracellular representation of the activation of the spinal cord. And the beauty of that is that you can use that as a target for to define a surrogate of neural activation. It's a biomarker. It's a biomarker for activation of the spinal cord. And so the strategy that's been highlighted in a randomized prospective multicenter double-blinded self-selected crossover study out to 36 months, which is really one of the pivotal studies that we have. It's represented as an investigational device exemption study. It is one where it proved the paradigm that if you can measure the activation level of the spinal cord and respond to it in a pulse-to-pulse fashion up to 4 million times a day, the hypothesis was, do people get better? And are those outcomes predictable? Knowing that the only variable that was changed between the control arm and the experimental arm was whether the physiologic closed-loop controlled therapy was turned on or not. And so when you look at that study, I think it clearly highlights the fact that it does work. And I think it was a beautifully designed study. Tim, you probably were a part of the design. You study everything. But it's really interesting because there was not only a comparative arm, there was also a crossover arm. And it was a double-blinded study. So people didn't know what they were getting, nor did they know where they were going or where they were coming from. And when you dissect the crossover part of that study out, I think it really highlights the fact that physiologic closed-loop controlled spinal cord stimulation works when you measure on a pulse-to-pulse fashion and when you respond on a pulse-to-pulse fashion. So, Johnathan, do you have any other words of wisdom there?
Yeah, I think what you said really summed it up well, but I think the other piece is that by doing that, you guarantee consistency, right? So it's the idea that if we have an understanding of how much of the spinal cord we're activating and what we're activating, and we're able to correlate that activation with pain relief, and I would even say maximal pain relief, and we have the ability to respond and measure every time we send a pulse as to how much we're activating, then if we're able to do those three things, then we can say activation of this much of the spinal cord will give maximal pain relief. And we can ensure that we give a dynamic output of energy to ensure that that activation is consistent over time, so that pain relief stays consistent. So whether someone's sitting, laying in bed, walking, running, playing with their kids, shopping at Walmart, like every Arkansan does, their pain relief is going to be the same no matter which phase of life they're in. And that, to me, is the real value proposition of a physiologic dose-controlled closed-loop system.
So I think that was a great explanation of closed loop. Jason and Jonathan, you guys both mentioned dosing. So, we dose medications all the time with our patients, right? So Saluda talks about knowing the dose and controlling the dose. So Jason, we'll toss it over to you first. Can you kind of explain a little more what that means?
Well, what is knowing the dose? We published recently, there's 2 studies looking at maximal analgesic efficacy associated with physiologic closed-loop controlled spinal cord stimulation. And the thought was we have all of these ECAP recordings, both in the Avalon study, the Evoke study, the ECAP study. And wouldn't it be cool if you could look retrospectively at that data and come up with an appreciation that everybody has a different physiologic signature of neural activation? That's the slope of the plot of neural activation. So everyone's got a different sensitivity. And we know that everyone's got a different threshold to generate an ECAP. There is a misnomer that an ECAP activation or the ECAP generation is equal to paresthesia. That is not the case. An ECAP highlights neural activation. It doesn't highlight paresthesia inducement. So those are 2 different things. And long and the short of it, if we can look at the threshold of an ECAP and you look retrospectively at how people do, you can then start to predict how far above an ECAP threshold would you need to generate maximal analgesic efficacy. And so this was published in a peer-reviewed article. I encourage you to look at it. Dr. Levy presented it at NANS. He presented it at Aspen. And it's essentially around 1.4 ECAP threshold. So when I talk to my representative in my clinic and we have someone that's got back and leg pain and we're doing a trial, for example, and the person's getting 40% benefit at day 1 or day 2, those are the measures that I ask. I look for how tightly controlled are we neural activating. We want it to be near 5 microvolts of kind of where the target dosing is. And we want that dose to be around 1.4 above threshold. So that's knowing the dose, and that's kind of controlling the dose. You control the dose by adjusting the output of the device to make sure that you're consistently delivering that dose. And we published on how fast can you see differences in a trial. And we have a 98% positive predictive value that at day 0, you can predict how well someone's going to do at day 7. And then Johnathan talked about this predictability and this durability. So Dr. McHale, he presented at NANS looking at a 3-month outcome to a 36-month outcome, showing that 90% of people had the same effect at 3 months than at 36 months. So it's a chapter in the story of saying that the way you're stimulating, because you're adjusting and measuring and responding to it, it is a durable feature. It is not a flash in the pan result like we see with some other fixed output therapies.
I want to ask a follow-up question to Johnathan about what you just said, Jason. So, that study on dosing, I posted that on LinkedIn after we published it, and had about 25,000 views in 48 hours. I think there's a big interest in that. But Johnathan, recently, we added a few years ago, basovertebral nerve ablation to our practice, and we look for that modic sign on the vertebral body. And we're talking about the era of biomarkers. And earlier, you mentioned the word biomarker when you were talking about the Saluda closed loop system. What is the biomarker here, and how is that going to change the field? Can you elaborate on that? And I think that relates directly back to the dose of the person.
Yeah, I'll say a few things, and I'll definitely get to your question as we discuss it. But just to highlight a couple of things that Jason said, we're changing the field because we are actually mapping out a dose response curve to how patients respond to electricity. And that is a completely new concept to how we are doing stimulation, where as I've heard Jason say many times, that previously we titrated from failure, in the sense that we basically try things and then we decide whether to go up or down kind of based on experience. A lot of times when we're programming stimulation, or the experience of the rep or the experience of the physician. Now we are actually mapping out the sensitivity of the spinal cord, which changes based on patients' physiology. It changes based on their pathology, their genetics, et cetera, and maybe even more, right? And we are able to then follow an ECAP, which an ECAP is basically a surrogate of how that patient's spinal cord is then responding to electricity in real time, basically giving us a biomarker to understand what's happening at the spinal cord level. And then we're able to use that to titrate an actual dose that we are now able to define retrospectively, that we're able to apply based on patients' individual physiology. So that dose is a ratio of their response to electricity based on their own physiology. And so we're able to potentially predict exactly how we should set, or the ECAPs that we need to titrate to, or the ECAP level we need to titrate to, and then keep it consistent over time, kind of really answering that question of durability in spinal cord stimulation, where if a patient loses efficacy, we now know based on retrospective data what dose of electricity that they most likely need or has been predicted to show improved benefit in a pretty large data set of patients. And that's been published and peer reviewed.
All right, so let's turn it back over to you, Jason, and talk about, like you alluded to earlier, the difference between the Medtronic closed loop system and the Saluda closed system. And if you have any experience with either one of them personally, you can talk about that as well.
Yeah, I mean, I can talk 30,000 foot view stuff. So I think like what Johnathan described and like what we've talked about, we're using the ECAP as a target when we're using the Saluda physiologic closed loop controlled evoke system. So we're using the ECAP as a target, and then we're using that as an anchor where it's individualized based on each person's sensitivity of the spinal cord, knowing that we want a dose ratio of around 1.4. And that's kind of the strategy. And then not only that, but we're using it as a target, and we're using it as an anchor to define the maximal analgesic dose. And we're maintaining that 4 million times a day on a pulse to pulse strategy. The Medtronic system, as I understand it, is one where it's more of a governor. So the ECAP is a surrogate for overstimulation. And so if an ECAP is triggered within their stimulation paradigm, it knocks the amplitude down, okay? And then it slowly will build up over time, as I understand it. And then if it gets another ECAP that's generated, then it knocks the amplitude down. And so I think, as I understand it, it records continuously. It doesn't respond continuously. And when you look at some of the information that's available as I try to digest it, it really adjusts around 10% of the time. So 90% of the time, you're in a fixed output therapy, just like you would if you weren't using physiologic closed loop controlled spinal cord stimulation at all. I think another difference that I think it's important to highlight is the fact that because Johnathan and I talked about the importance of the confidence of neural activation and the consistency that it's required to deliver durable outcomes, the way that you're stimulating the spinal cord during the trial is exactly the same way that you're stimulating the spinal cord at 36 months. And since commercialization in October of 22, I've seen that within my practice. So no other no other spinal cord stimulation therapy, I have the confidence of the predictability of what life is going to be like after the trial. When you talk to Sam El-Dabi, he says trials are worthless. And it's largely because we're in a black box. We don't know how much electricity we're giving. So the trial is important. With the Medtronic system, as I understand it, there is no physiologic closed loop controlled stimulation therapy available during the trial. It's only available as a salvage to their paresthesia free paradigm, where I think they're stimulating glial cells.
So let me follow up on that. I think it really brings an important question up. We're seeing a lot of our 3-year patients back from Evoke who are still doing very, very well. I've been really impressed by how well our study patients have done, and now our real world patients in our new study, Ultra, are doing very well as well as they come back for those 3-6 month visits. So Johnathan, we're learning more and more as we look at things like health, longevity, that the anterior cingulate cortex changes over time. The epigenetics, not just in the person, but over time and in our ancestral bodies. But we know that it does change in individuals and that their nervous system changes. Something as simple as smoking, for example, may change your neural system. What's the future here of automated programming that changes with the patient as they age, as they're ill, as they develop neurological diseases? You think there's going to be a path where we can continue to have that same outcome with time as people change?
Yeah, I have kind of two answers to that question. So one is kind of taking us back to the data of the Evoke study. And if you look at patients who did well at 3 months, who were responders at 3 months, there is a greater than 90% chance that they would be responders at 3 years, which is data that I think is really kind of mind-blowing in our space, because that's not something we've seen. One, we don't often go out to 3 years, but then two, really showing that once someone's a responder, they stay a responder. So getting to that durability piece. I think the second thing is going back to the neural metrics that we are measuring in spinal cord stimulation and the data that we're collecting. So when we look at a patient now that's using this system, we are measuring a dose response curve in ways that we don't get that specific with even all the medications that we prescribe. So we are taking a step into the future past the way that we currently do medicine. And one can say it's almost tailored medicine at this point. Two, we're able to know what the dose is. So how, based on their dose response curve, basically how they'll respond to electricity. But then we're also looking at dose accuracy, which is something we haven't even discussed yet. And that's how tightly the system is able to maintain that dose. And so by using all of those metrics over time, if someone's genetics are changing, then one would argue their dose response curve would potentially change. And if we're able to measure dose response curves, and as we talk about autonomous programming and AI and the future of this technology, then we could actually potentially track those changes over time. And then we have the ability to dose based off those changes and then respond to them. So the ability to look into what's physiologically happening in the spinal cord, one, basically the physiologic makeup of the spinal cord, but then how the spinal cord responds to therapy, gives us so many options in the future that we don't have right now. And honestly, we are maximizing using those metrics now to really improve outcomes currently.
Yeah, I'll highlight a couple of things too, that if you remember back in the day when Kumar talks about habituation and tolerance, what did he say to do? He said, turn the device off, give people neuropathic pain medications, and then turn the thing back on. And you could salvage about 30% of patients that way. And what's interesting is when you look at measuring the activation of the spinal cord, is there a pharmacologic effect of neural activation? The answer is yes, for sure. And we know that it's harder to neural activate the spinal cord when you're on things like gabapentin. And so when we're talking about salvaging spinal cord stimulation, the strategy of giving people Lyrica or gabapentin or something to try to improve stimulation therapy actually did the opposite, because it made it harder to neural activate. Now, is that a consequence that we were overstimulating the spinal cord and that dampened it back down? The challenge with fixed output systems is that you don't know. You don't know which direction to go. And I think Johnathan said it earlier, but we titrate from failure when we're using a fixed output system. So when we look into the future and we're looking at tailored medicine based on the other medicines that you take, it will change the sensitivity of the spinal cord. It will change that slope. And so is there a future where people will program themselves based on the medicines that they're on? Time will tell.
Yeah. And I'll even add one more thing to that. With data comes intentionality. And when you don't have data, you have to guess. And that's because you don't know what's going on, in a physiologic way. But now that we have more data and we have these neurometrics, if we have patients who aren't doing well, then we can, our rep or us, or depending on kind of your practice, can actually use those metrics and track those metrics over time to make intentional changes that we know based on the literature have been shown to get people better and improve outcomes.
Yeah, I agree with both of you guys. I think this is why this closed loop stimulation is such a game changer in our space, and kind of circle all the way back why the explant rates have been higher for stimulation in general. And Jason, you published on that as well. Could this be the answer? Could this be the answer of decreasing this and improving patient outcomes?
Well, I am always fond that people bring that up, that I published that study, and I had a lot of help to do it. So thanks for that. I appreciate that. Yeah, I mean, spinal cord stimulation, I think when you get your hands on it, I've been a huge proponent for it. Spinal cord stimulation works. And I think there's probably lots of ways to neural activate where you're going to get success. I think the question is, how long are you going to have that success? And when we did that explant study, again, 100% of people got explanted in the study. So we just asked the simple questions, why? Like, why did you get your device out? Did you need an MRI? Was it that you had an infection? Was it that you had loss of efficacy? And as you can imagine, the vast majority of people that were explanted identified that the device stopped working. Why is that the case? We don't know. I mean, if you go through kind of the normal programming of how we do fixed output systems, we give someone stimulation and then we send them out into the world and we say, gosh, I hope that works based on population data. And it may be founded in an IDE, but I think everyone in our space is a little data tired because there's so much data out there. It's hard to know what to believe and who to and what to read these days. And so I think it's the translatability of what we see in peer-reviewed literature and what we see in the real world. And people would come in, they would get stimulation therapy. We would try our best to program them appropriately. And then we send them out, and then they may come back in 2 weeks or 4 weeks or in 3 months, however the clinic is set up. And then they come back in and then they say, well, my back still hurts or my leg still hurts. And then you don't have any more information than what you did 3 months before. And so again, measuring the activation of the spinal cord, that gives you confidence in identifying a differential diagnosis. Is it facetogenic? Is it sacroiliac? Is it something else that's going on? And that's how we use it. You know, I spoke with a few colleagues recently, and I think that when we talk about spinal cord stimulation, we talk about spinal cord stimulation trials, we talk about representatives of the company. When we have data like a physiologic closed loop controlled therapy, they are actually electrophysiologists of the spinal cord, right? And it just changes the conversation. It changes, I think, the confidence in the delivery of that information because it's diagnostic. I can tell you whether you're going to respond to stimulation therapy or not based on the dose that you have. And if you're not getting a response, I can tell you neural activation is not going to solve your problem. And we've never had that confidence before. So you can look at it on both sides.
So I want to ask a final question to Johnathan, and we'll have some closing thoughts. But, you know, Johnathan, I was involved in the early design of Evoke with Dr. Levy, Dr. McKell, several of the PhD geniuses at Saluda. And the explant data has been very positive for those patients. And now we're seeing very similar results in the real world, which other companies have had trouble matching in the real world. But the New York Times, and I know we have some members who like the New York Times. We have some members who don't trust the New York Times. The New York Times came out with an article, what old people should be worried about, right? What seniors should be worried about. And one of those things was spinal cord stimulation, right? And we probably all had a patient ask us about that. I know I have. So the question I have for you, and this is, I think, a good way to kind of wrap up maybe what this means to the field. You know, when you say to that patient, well, that has been true in the past via, you know, Van Buyten study, Pope study, Hayek study, there's been some failures, but now we're not seeing that same type of failure rate. And it's because of, can you say that Saluda closed loop is a solution? And why, how would you tell a patient that's different than the previous experiences?
Yeah, no, I think one point, and then I'll kind of answer your question. I think one of the challenges that we have in our field in general is that we study patients that medicine has already failed, right? Like if there was a surgical fix for post-laminectomy syndrome or failed spine pain, whatever you want to call it, that they wouldn't be in our offices. So, you know, to compare our study to a cardiology study, I think is always really challenging. But even going forward to your question, what I tell patients is we are moving towards being able to tailor therapy to their pathology and physiology in ways that we haven't before. And so when we think about how we're delivering spinal cord stimulation, I'm able to actually show patients their dose response curve and say, because you've had X disease for so long, you are very sensitive to electricity, and that is going to change the way that I deliver therapy to you. And that's and that gives patients the confidence that I am actually collecting data and actually dosing them with therapy in a way that is not based on a population, but it's based on them. And I think as we start to tailor medicine, just like we do in cancer, tailoring chemotherapy improves outcomes. As we tailor spinal cord stimulation, I think we'll improve outcomes the same way. And that's what we're seeing in the data currently.
Yeah, I'll comment.
I just have one more quick question, Tim.
I was going to comment briefly.
Go ahead.
I recently had a patient ask the very question, and the way I approached it was very similarly, just to say that I think we did the best that we had with what we had available at the time. And we are empathetic, and we're trying to help people that are in pain, that have had pain for, statistically greater than 8 years, that have pain that is on an intensity level of at least 6 out of 10, and they failed other therapies. And so we did the best we can with what we had, and now we have something better. And we have something better where we can guarantee neural activation. And whether that neural activation is therapeutic is the purpose of the trial. And if it is therapeutic, the data would suggest that you're going to have the same outcome 3 years down the road than you do right now. And we've never had that before. So all the failures with spinal cord stimulation preceding physiologic closed loop controlled spinal cord stimulation are a consequence of a fixed output paradigm, whether you feel it or not.
That's great, Jason. Let's just wrap this up with kind of the outlook, the big picture of this, and maybe just 30 seconds response for both Jason and Johnathan on this. In the next 5 years, where do you see this going? Are most companies going to be turning to closed loop stimulation, you think, where you're activating, getting some kind of objective measurement and then recalibrating? Do you think more companies are going towards this stuff? What are your thoughts? Go ahead, Johnathan.
I am happy that companies are moving towards closed loop technology. And I'm happy that companies are moving towards biomarker based technology, right? Because I think we do need more data, and understanding what's happening at the level of the spinal cord, I really believe is the future of our space. And so I think that as we see improved outcomes with closed loop technology, I think that more and more companies are going to try to figure out ways to close the loop. And closing a loop is basically figuring out how to respond in real time to what's happening at the spinal cord. And so other companies may use ECAPs, some may use ECAPs, some may use other ways to try to respond. But either way, I think that responding in real time is going to be the best way for us to improve our field. That being said, when you look at the data right now that we have, using an ECAP as a surrogate for spinal activation, which we know is what causes pain relief, and having a surrogate that we can respond to has really been shown to improve outcomes currently. And so I think right now it's the best way to respond in real time to pain relief that we have at the current time. And that's literature based, and I think we should follow the data.
I'll respond also. I will say that when you look at other areas in medicine, like diabetes, and you look at continuous glucose monitoring, and you look at how that revolutionized the way that we manage diabetes, I think we are definitely seeing that with neural activation of the spinal cord. And whether you believe in what is the physiologic signature that can be identified as an endpoint and then titrated to, as Johnathan describes, we know that inherently, if we're placing something in the epidural space, we have to respond on a pulse-to-pulse strategy based on the data we currently have. So I think the future is now in terms of leveraging physiologic closed-loop controlled therapies. And I think in the world of spinal cord stimulation, we have one that does so on a pulse-to-pulse strategy. And I think it will be table stakes moving forward. I think everyone's going to have to come up with some strategy because it is a tailored approach. It is not population medicine anymore.
Well, thanks, guys, for joining us. Tim, we'll get you the last final thoughts, and then we'll wrap it up.
Yeah, no, thank you. And Johnathan, Jason, fantastic job. I loved your thoughts, and I learned a lot from both of you tonight. Thank you. And a couple thoughts. In 2011, my good friend, Professor Michael Cousins, introduced me to John Parker in Sydney. And I became an advisor to John Parker, and I didn't understand ECAPs. I never heard of ECAPs. And John made it sound so complicated as a PhD neurophysiologist. And so, I think what we've learned the last 13 years is really how to take that complex thought process and make that into a biomarker dosing really paradigm we can use to improve outcomes. So I think we've came a long, long way. My other point of that would be that it's not easy. So when Jason compared the two current closed loop systems on the market, the reason that Evoke is so complex is because it took 13 years to get where we are today with that. And it continues to evolve as we have new research. So I do think that Jason and Johnathan are right. Other companies will have to come forward with some form of a way to close that loop, but it's not very simple. It's very complex and it takes a lot of investment, research. The good thing for all of our members is you'll have a chance to do a lot of research with a lot of different companies, because I think each of those companies are going to have to step up to the plate, because this sets a new bar. This sets the age of biomarker medicine. I think that's going to be the most important takeaway from this discussion tonight. This is a new age of, targeted, individualized biomarker medicine that will change the space. And so with that, Patrick, I think it's been a great discussion, and I think your choice of guests tonight were really spot on. Thank you for doing such a great job.
Yeah, I just want to thank both the guests, especially Jason. I've been trying to get you on since episode 1. So it's only taken you 20 episodes to get you on, but I'm glad you're on. You did a great job. And like you mentioned, I owe you a lot. You and Tim have been huge mentors for me, all the way from that system trial they talk about. And you guys been getting me on a lot of these studies and publications. So I really appreciate all the work you do for me and for everyone and your patients as well. And Johnathan, it's been great getting to know you through Aspen and through closed loop stimulation. I don't think anyone does it better than kind of simplifying this stuff, which is so dense, as Tim alluded to. So thank you again for joining us, and looking forward to hearing more about this and data in the future. So this wraps up episode 9, season 2 of the Pain Unfiltered podcast. Thank you all for joining us.